Hey everybody, it's Dr. Eric Balcavage and Dr. Erica Riggleman. We're back for another edition of Thyroid Answers podcast. And today we have another guest, and we're going to do another kind of dive into hypothyroidism and hormones. And today we have Dr. Meaghan Kirschling, who is a Doctor of Chiropractic. She's got a BS in nursing, exercise science, master in nutrition. She's got 2 masters in nursing. Essentially, she is educated for us, right? She makes us feel like we don't do anything. I think I'm busy, and then I read Meaghan's her bio, and I'm like, oh, what am I doing? I haven't accomplished anything. But Meaghan, we're happy to have you on the podcast. How are you today?
I'm great and so happy to be here.
Awesome. So we are going to do a little bit of a deep dive into hypothyroidism and hormones and kind of tie together. We've had other people on and talked about hormones, Dr. Carrie Jones and a number of others, but I think we're going to take maybe a little different take on this today. But before we start talking about hormones and hypothyroidism and kind of start peppering you with a bunch of questions, how about we give us a little bit of backstory, because there's a lot of education here, and you're in a space where somebody might look at this and say, holy cow, how does she have time to do anything except study? But what is the story? How did you, A, get involved in this space, and B, why did you spend so much time getting into all this education?
Yeah, so it all started, I think, actually with my own journey, as many of us that have, I think, dived deeper and looked into having solutions that make a difference. A lot of us have our own story. Mine was at a young age, and the story isn't that, my health took a complete plummet, but it was sort of interesting because I was a college swimmer. So I swam Division I. So my whole childhood was based around swimming and competing. And that's the only thing I really cared about when it came down to it. And I started to have just a little bit of hormone problems, nothing, huge, but just something wasn't right. And it, now looking back, was probably a lot to do with swimming and being an athlete and things like that. But I knew that something wasn't right because of swimming. If not, I think I would have just followed the path when I went to a doctor and they told me, you're fine, you're going to grow out of this, you're going to be okay, that I would have taken that as an answer and been just fine with it. But even at a young age, when I went and they just wanted to put me on birth control and just sort of mask the symptoms, that I just said, this isn't right. There's got to be a reason. I take care of myself. I work out, even at a young age, really cared about nutrition. So I know that this isn't just my destiny, or that my body just has decided it needs birth control pills. And looking back at it, and even, at about age 18, I remember going to a doctor and her telling me that I was being ridiculous and just downplaying everything, and that I had a solution, and it was to go on birth control pills, and that, I just needed to accept that and pretty much get out of her office. And I remember thinking that this is just a weird thing to tell an 18-year-old, that, it was sort of going to lead to, for a lot of other people, body image problems or things like that. And I was just like, this isn't right. But I forgot about it until actually after my senior year of swimming at the college level. And my swim coach, who sort of a very odd man, he really wasn't very in tune to a lot of things. He pulled me aside and just said, something's wrong with you. I don't know what it is, but something's wrong with you. And it stirred something up in me where I was just like, okay, this man who, we had a really weird relationship, as sometimes you have with, coaches and athletes, and just that he picked up, in a medical world, that something was wrong with me. But I'd been to these doctors and they had said, there's nothing wrong with you. So that sort of started this whole sort of journey for me. And like I said, my health problems weren't that huge, but it just didn't feel right. And I didn't accept the answer that my body wasn't trying to tell me something. And that led me down the road to look at my own hormones, to realize that I wasn't going through a birth control pill deficiency, that there was something. Yeah, I know. I diagnosed myself too that I wasn't birth control pill deficient. And luckily I know, and that was before any of my degrees. And luckily I actually didn't even choose the birth control route. It just never felt right to me, but I did what a lot of people do when they're told that nothing's wrong, and I just ignored it for years. And that's when I really decided that I didn't want to go down the road of medical doctor, and nothing wrong with that. It just didn't feel right to me. And that I realized functional medicine and looking at this dysfunction, because I definitely was not in a disease box. I was not in that perfect, here's your diagnosis, this is what you have, now here's the pill. But I had dysfunction. And I think that started my desire, and then realizing that a lot of people do have it worse than me, and they're given the same answers. And I just don't think that that's right. I don't think that's fair. A lot of us are in dysfunction, and we need to find the reasons.
Yeah, and I think that's a great point, and I think something we'll talk about in a little bit as well as we kind of go through the questions we want to pepper you with. And one of those is dysfunction versus adaptation. So I want to spin back to that in a little bit. I know we've had this conversation on your podcast a little bit, but when it comes to hormones, right, and we're talking about what's going on with people, where do you see the biggest challenge with hormone physiology and how it's looked at today regarding evaluation, testing, let's start maybe from a medical perspective or an allopathic perspective. Where do you think the problems lie?
Well, I think there's a lot of reasons and a lot of ways that it's sort of approached incorrectly. One of the main things is that I think we try to make hormones a one size fits all. And I always tell people, because, I get a lot of people come in that are worried about hormones because of Women's Health Initiative, which we can talk about a little bit later too. But, back in the early 2000s, we had said, let's put everybody on hormones. And then, 2002 said, whoa, this is bad, and really scared a lot of people. But we still sort of have that one size fits all. And the word that you said that really does need to sort of be acknowledged and realized is that hormones are a huge adaptation. They're a huge compensatory mechanism for us. So a lot of people that are coming in, the first thing we have to do is find out, are hormones primary? Is this a situation where these pathways have gone off and we need to support them to get them back on track? Or are they secondary? And that's a lot of the times what it is. So me flooding you with hormones, whether it's bioidentical or whether it's hormone pathway support with different supplements, isn't going to help you if we don't get after the cause of what your body's trying to do with hormones.
I think that's really key and important. I try to make patients understand that there's a reason why something's going array, whether it has to do with the thyroid pathway or autoimmunity, or we're dealing with hormones. There's something that's contributing to it, and your body's not making a mistake by lowering hormones. There's a mechanism that's causing that. You can look at it as God didn't make a mistake by making certain people have good hormones and other people having low hormones. There's a reason why that's happening. And I think that making people realize that just by taking hormones doesn't fix the underlying problem. And that's why a lot of women fail at hormone replacement, is because as they come off of it, they've got all the problems again because they never fixed what got them there in the boat in the first place.
And a lot of people do hormones very boutique-ish. You come in, you're low on hormones. I might not even check you. I'll just give you the same hormones I give everybody and hope you do okay with them. And I just think no matter what, if that's the recipe in any part of life, that's a bad recipe. So for some reason, we think that that's an okay recipe in medicine sometimes, and even nutrition and supplements, that we can find these protocols that are going to work for 80% of people, and we can give them to 100% and then just tell the other 20% that didn't respond well, you're just crazy, or, this worked for 80% of other people, so this must be you. Well, it is you, but there's a reason for it. And exactly like what you're saying is, let's get after the reason why this is happening and you're not reacting or responding the way that we would expect.
Yeah. So let me kind of spin onto that with your opinion on this. And that is, the reason we have the challenge is that in functional medicine is, I think, because what happens in functional medicine a lot of times is we're trying to do what allopathic medicine is doing. Allopathic medicine's strength and really strong point is in acute care model and keeping us alive, right? So that's the benefit of acute care, medicine-based care. The problem occurs is that when we try and say that, okay, that's the same approach we can take to get somebody healthy and get them well, and it doesn't work well, right? Because if I'm bleeding out, yes, I want to stop the bleeding, right? If I'm having a heart attack, I want to stop that immediately. But just like we talk about in thyroid physiology, you could have line 10 women up that were 10 men who have hypothyroidism, and they could have all gotten there for a different reason. If you've got estrogen imbalance, androgen imbalances, cortisol dysregulation, any of those things, everybody got there for a different reason. And so this idea that if we just normalize a value that normalizes health is just crazy. it works well in crisis care. If I'm having a heart attack or my blood pressure is elevated, we don't care what elevated the blood pressure right now. Right now, what we need to do is get this blood pressure down so you don't have a stroke. But that's not healthcare. That's crisis management. And when it comes to hormone therapy, maybe I think you can build off of this a little bit, is that what we see both in allopathic medicine when it comes to hormones, in my opinion, and to some degree in functional medicine, is people just want to normalize a lab value and assume that that is normalizing a person's body chemistry, whether that's hormone replacement therapy, whether that's the birth control pill, whether that's a bunch of supplements that they can, hey, let's just increase your estrogen. Okay, but does that really fix the problem? Would you kind of agree with that thought process?
Yeah, and I mean, from being a little bit in both allopathic and alternative, traditional medicine and alternative, and being in both arenas, it's been sort of easy to step back and see some of the driving forces of both, and that they both come from a good place. But, you know, when you look really at like traditional medicine and allopathic, it's interesting to me because they really are trying to simplify things. And I tell people it's not because, you know, doctors aren't super smart, but they really do want to make it sort of pathways and processes and templates that everybody can do the same. So they're very good at knowing what to do or giving directions on what to do for one value. Like if you have a high cholesterol level, here's the pill for that. If your TSH is off, don't look at anything else in the thyroid. And then this is what you're going to do just on the TSH. Because if we started to bring in T3 and T4, like that's just too complicated. And that's going to start to bring in these other variables that we can't control. If your blood sugar is elevated, you know, this is the formula for what we should do for those patients. Really, really good, like you said, in emergency medicine, because you can sort of zone in on that one thing that at that time is severely injuring or affecting that person. You know, if they're bleeding out, stop the bleeding. If they're having a stroke, let's decrease, you know, that TIA and what we're going to do for that. But it's not great when we're looking at dysfunction where it's taken all these other systems where, you know, the hormones go off and then your immune system goes off and your nervous system goes off and your GI system's all connected in there too, that all of a sudden now we have to look at all these wheels in motion and we have to put in our own brain power and we've got to solve those problems, find what's primary, secondary, and it's harder. And, you know, medicine is a business. It's a business for everybody, because that's just the way it is. And honestly, the way that I think traditional medicine is made up, it's to allow, you know, and I'll say this because I think it's true, it's to allow insurance companies and pharmaceutical companies to make a profit. And they've gotten good at that. They know how to do that. And they know which medications are going to make a profit because they have a simple template to them. But it doesn't make a lot of sense for a lot of patients because a lot of patients are in dysfunction.
Mm-hmm. Yeah, those are two different things, right? We've got a business side of the model that's organized around generating income. And one of the best ways to generate long-term income is to have a long-term patient. And one of the best ways to have a long-term patient is to never get them better, but just manage their illness. And unfortunately, I don't think, we've said, Dr. Erica and I have said this on the podcast many times, we don't think it's bad people per se that are creating problems. Everybody's got the right intent. It's an industry that's a problem, right? It's just the way it's set up. I think I was having this discussion with somebody the other day and they were talking about the cost of healthcare and they were they were complaining that, you know, they're not getting better in the cost of healthcare. And I said, listen, you're seeing all these doctors and you're paying you're paying for their care, but if you had to pay for that out of insurance, would you keep going to those doctors and keep paying for that? And they said, no. And I'm like, well, why wouldn't you pay for it? I'm like, because I'm not really getting better. And I'm like, but then why are you still seeing them? Mm-hmm. And they're like, because I'm paying for insurance. I'm like, yeah, that's a problem. People have this feeling like they're stuck. They have to do what a third-party insurance company is dictating to them to do. Yeah. And the medical doctor's working in that model, the patient's working in that model. So it's really hard to think outside that box and say, man, these things aren't working. Maybe that's not the people, maybe it's just the model just doesn't make sense. And
Yeah.
I got way off target there, but anyway, let's get.
No, I mean, I think it's an important part to all this too, because you see it with hormones now too. I mean, it's interesting because like what you were saying is so true, is that it's interesting because I think everyone's sort of trying to find the middle, but you find sometimes now too that alternative practices are trying to become more and closer to replicate traditional, and you start to see traditional doctors start to say, wait, no, I want to actually dive deep into this and try to meet somewhere in the middle. And with hormones, we see it all the time because we do see all these places now that are popping up. They're maybe not as common in the Midwest, but we see them a lot on both coasts, East and West, where they're trying to really make hormones easy. And the simple fact is hormones are not easy. They're very, very complicated, and they're very interlinked with so many other things that if I'm just going to do a one size fits all with hormones, there are some people that will notice some improvements, but I'm going to mess up a lot of women's lives.
Mm-hmm.
So there's a big connection between hormones and other systems, right? And so we could do 10 podcasts on that.
Yeah.
Right? But there's definitely a connection between hormones and other systems, GI, immune, nervous system, thyroid physiology, right? Sleep and wake cycles. So how would you kind of explain the connection between hormones and those systems, and why it's maybe more problematic when you see somebody who's just understanding estrogen, testosterone, and not understanding those other systems?
Well, the first thing that I always tell people is, when we look at this, a lot of times the nervous system, hormone systems, which includes thyroid and adrenals, your stress responses, and then estrogen, testosterone, progesterone, all of those systems along with your nervous system, I really think that when you look at it, it's all should have been one system. We separated it because it looks good in a textbook. It's easy to say, this is what the nervous system does, and these are the nerve cells, and it's different than the hormone system, and this is the endocrine system, and this is what it does, and then this is the immune system. But once you start to dive into this, you really realize they're one system all playing off of each other. And I actually think the main part of that is the immune system, that it's the immune system that's giving the signals, that's saying, okay, you can go ahead and operate as normal, or wait a second, I'm going to need your help compensating for something going on. And when we look at it, then many times, and this is what a lot of people see, is that when the hormone systems goes off, you're not seeing just, hot flashes, or not just seeing changes in your cycle or things that we know are very hormone based, but you also start to see all of this cascade of events, because no matter what, those other components, the nervous system gets involved to try to compensate. The immune system tries to compensate too, or it's the immune system compensating and the hormones are making up for it. So I think one thing that is really important is that we look at all three of those systems as one, because I really think, when we talk about the neuroendocrine immune system, it really is one that we just divided because it's best in a textbook to teach them separately.
And I think that's one of the hardest things to get patients or even other doctors to realize, that it is all one system, and that, patients coming in who's got some sort of neurodegenerative problem, something going wrong with their nervous system, and those can be actually very much linked to their hormones. Look at patients who have hormone issues. They're probably going to have anxiety or depression that go along with some of those nervous system symptoms. And so it's all intertwined, and you can't just treat or even, try to address one without addressing all three. And that can be the hard link between it, is that you've got to look at all three to be, successful in most cases.
Yeah. And I think that that's where we a lot of times do a disservice to patients, is that when someone comes in with these symptoms and they're hormone-based symptoms, to not link this to all the other things, because it is especially that triad, I think is so important, is that nervous system, immune system, and the hormone system.
So we're going to tie in a little bit, and I don't think you'll have a hard time kind of maybe agreeing with this thought. When we look at thyroid physiology, we look at it many times more, not the mistake that the body made, like, oh my gosh, the body, the intelligence of the body just decided to shut down thyroid physiology for no particular reason, or attack the gland. Somehow we came from two little cells and became what we are, but yet somewhere along the way, the whole system just broke down and lost its way. Well, how we look at thyroid physiology, and I think both of us have looked at hormone physiology the same way as an adaptation to some type of cell stress. And I'm sure you're familiar with the cell danger response, and how when the cells are in stress, that the body changes how hormones work. Would you agree with that? And would you say that is, you see a similar thing happens with different aspects of hormone physiology, whether it's estrogen, testosterone, cortisol? Can you build off that a little bit?
I think many times, and it's important for people to realize this, is that your hormones and your body is doing something right to something that is wrong or something that is off. And that's really where we need to start, is because what's happening, whether it be something like hot flashes, whether it be your period is off, whether it be weight gain, it's a response that is normal. And just like you guys are saying, your body doing something that's right, but that there's something that's triggering it, and that this is a response. And hormones, I think almost more than anything else, I think thyroid's probably in there too. We see more and more problems with it because there's such an environmental link. And a lot of times, we can't fix somebody's hormones until we address the environmental distress that their body's gone through with a lifetime of hormone problems and molecular mimicry from hormones that are in our environment, and things like that. So a lot of times, those are things that we have to address, and we see that a lot more with hormones and some of the other things that come in to the office.
Mm-hmm.
So when we talk about the things that might cause problems with thyroid physiology, and we'll get into some of the testing in a little bit, but when we talk about the things that might cause disruption or changes or adaptations in hormone physiology, what are some of the most common things you see? Maybe you already alluded to, maybe xenoestrogens or chemical compounds that could change physiology. What else do you see as some of the leading things that may create hormone imbalances in individuals?
So stress, I don't think we can have a conversation about hormones without talking about stress. If we just even look at the basic hormone pathways, I always tell people there are three columns. There's the progesterone column, there's the stress or cortisol column, and then there is the testosterone and estrogen and DHEA column. When we look at those three columns, one of them is cortisol and stress. And so there's no reason for someone to come in and want bioidentical hormones or want a hormone detox if they are just burning through that stress and cortisol, because of two reasons. First of all, because they're going to be taking all of their hormones and shifting it to that one pillar of stress. And so many of us, I have a lot of people that come in to see other doctors, other functional medicine doctors, and they've changed their diet. They've tried to change their sleep patterns, and that's a very hard thing to do. They've changed, some of their lifestyle and exercise, but they haven't even talked to them about stress reduction. And, that's, I think, a really important thing to look at. Plus, cortisol not being off is going to cause weight, and an increase in weight and weight storage. And we now know that weight and fat, especially visceral fat, is not an inert storage device. It mimics and causes hormone disturbances and disruptions, and it stores those hormones to cause more hormone imbalances and problems. So we have to, really go after that in order to find true balance and get somebody back to a better state of homeostasis or balance.
So when you're talking about stress in that point, we typically talk about stress as physical, as chemical, as emotional, and microbial or psychological, right? And I think that when you're talking about the stress in that aspect, you were in that situation, you were talking about, hey, the psychological stress. They're working on diet, nutrition, all those things. One of those things, a lot of people don't look at the emotional stress and how it creates problems, or psychological stress, how it creates problems. But I try and point out to people that if you had a head trauma, that will cause a damage to your brain, right? You can have a concussion of the brain. But if you have a lot of emotional and psychological trauma, that's like having a concussion of the mind, right? Yeah. It changes how we think and how we internalize things. And then that creates this kind of fight or flight response in the body. And when you're in fight or flight, which is, I think, one of the things you're alluding to is, we're not in, build, and we're not rest and relax and build mode. We're in fight or flight mode. Mm-hmm. And so that I think sometimes we lose touch that we have to, in our medical or in our kind of geeky science world, when I'm looking at a patient's labs, I'm really looking at the balance of like the 17, what we call the 17 keto steroids, right? DHEA, those things that you're talking about, and those 17 hydroxysteroids, which are like the cortisol and those types of things. And if you see one aspect of that is really jacked one way, or there's an imbalance in those two things, you know your patient's more in fight or flight. There's no way that flooding their system with more estrogen or testosterone or DHEA or progesterone is going to, it may help make the numbers look a little bit better, but ultimately there's an imbalance there that for us as physicians, we have to be able to say, okay, yeah, I got a person who's maxed out here in stress, they're in chronic fight or flight. Before I dump a bunch of stuff into them, I need to fix that. Would you agree with that?
Yes.
And I think sometimes it's not even what's currently going on emotionally for them. You know, people will come in and say to me, oh, well, I don't have any stress in my life. It's completely gone. But what was it? What was your stress? Did you work in a really stressful environment? Did a lot of things happen to you? Did you go through a lot of deaths, divorce, moves, you know, in your lifetime that maybe you're still holding in? You know, they say we can hold emotional triggers inside of our nervous system, and sometimes that can manifest as a hormone issue and present that way. And so I think it's good not only to look at what's currently happening, but maybe stuff that's happened in the past that we need to kind of do some self-work. You know, in functional medicine, we're often working from the outside in, and sometimes we have to kind of start with the inside and work out about things that we're holding in.
And I see that all the time because I get this quote a lot, is that somebody will say, I mean, I have some stress, but it was nothing like a year ago when I went through the divorce or lost my loved one. It's like, okay, but now you're seeing that the body can't compensate for that anymore. Now you're seeing that you got through that time because you were probably in fake it till you make it, fight or flight, but now those systems are crashing. And the other part that I think is so important to talk about too is that does lead to another thing that really sets off hormones a lot of times, which is insulin resistance. And, you know, I don't think it's right to have a conversation about hormones without talking about insulin resistance, because a lot of times that is the key to what's going on with hormone imbalance, because people are in insulin resistance, and insulin is just a mean molecule. It will feminize a man and cause testosterone to aromatize to estrogen, and it will masculinize a woman and turn estrogen into higher levels of testosterone and DHEA. And so a lot of times too, we don't even have to touch a hormone. We've got to get that insulin resistance under control to find balance in somebody.
And that kind of goes back to what we were talking about, you know, it's all tied together, because hands down, if somebody's got an insulin resistance problem at the cellular level, they've got a thyroid issue, because you need thyroid hormone specifically for those GLUT4 transporters. That actually is what insulin's used to bring glucose into the cell. There are a bunch of other glucose transporters that don't require insulin, but the one that does require insulin requires T3 in the cell. And if the person has cellular stress, they're deactivating thyroid hormone. They're not going to be bringing glucose into the cell. And we look at that like a mistake, like you just eat too much and you don't exercise enough. But if we think about it from a logical standpoint, if I'm a cell in stress and I've got something threatening me, right, a toxin, an organism, something like that, do I want to bring more glucose into the cell, or does it make more sense to not bring more glucose into the cell, make that cell more insulin resistant, activate the autophagy response, right, self-cleaning, clean up, figure out what's going on inside the cell, and go after that? So we have this tie-in. I got hormones, I'm having a hormone issue, I got an insulin issue, but I also then have a thyroid issue because there's some type of cellular stress, which when we think about all of this stuff together, it still comes back to foundational issues, right? It's physical stress, it's chemical stress, it's emotional stress, it's microbial stress that drives the body to change the physiology, to adapt. And if you're struggling with chronic hormone issues, whether you think you're emotionally stressed, or I don't think I have any organisms or whatever, those are the key things that we have to take a look at. And I'm sure in your practice, for many of the patients, I have a patient who's got a hormone issue. She said, I just need hormone support. I don't have any problems with my GI tract, right? We just had that discussion. We finally I convinced her to run a GI map test. And which is, for the listeners, it's essentially like a DNA test for the organisms that may be out of balance in your GI tract. And I think every potential opportunistic organism and she is pegged off the chart. Now, she doesn't have GI symptoms, right? She doesn't have any, and she swears to me she has no problem with her GI tract, but she's got a hormone issue and no libido. Well, think about that. If somebody's if they've got this chronic overgrowth in their GI tract and potentially peripherally, is the body in fight or flight, or is it in sex and relax and digest, right? Do you see that the organisms are a major potential trigger for hormone issues in your patient base?
Yeah, and I mean, one of the things I say a lot of times too to patients is hormones really are, and hormone balance and reproduction is a privilege to our body and mind. Like we can give that up pretty easily in our body and minds and be okay. We don't have to reproduce like we have to, obviously get oxygen to our brain and get our heart pumping. So it's one of those things where a lot of times people do come in and they think they're going to sit down and talk all hormones with me, and we get onto their digestive system and they're like, okay, but I don't have a single digestive issue except I've been constipated, my whole life, but that's my normal. I get gas and bloating, but it's not as bad as it was, 5 years ago. Or we go through their medications and they're on, a stool softener every day. They're on a laxative. They're on a acid suppressing drug, things like that. And where it's like, okay, well, you have GI issues. And they're like, no, but I don't, my GI issues aren't why I'm here. And it's just good to realize that we really do have to look at everything because it is all connected. And almost every time the hormones are going to be because of something else. And when we look at it too, I think the reason we see more need for bioidentical and hormones and things like that in menopause is because a lot of those systems then have started to go into retirement, and they've started to take away their ability to compensate as well. So you start to then see these hormonal problems that, unfortunately sometimes hit women in the face and are just like, oh my gosh, like I can't ignore this because I can't sleep now. My libido is nowhere to be found. I have hot flashes. I just feel awful. I feel irritable. I just want to yell at everybody and cry at the same time. And the thing is that what's happening there is that you're getting these shifts that all of a sudden show these imbalances that have been there. A majority of us are, unfortunately, what I call walking time bombs of just waiting for our body not to be able to compensate anymore for things going on in our gut. So, it's not that functional medicine doctors are just one-trick ponies and we all go to the gut, but it's just fascinating because after you've been doing this for so long, there's always that big connection to the gut because of how that does interfere and change the immune system, the nervous system, and the hormone system.
Mm-hmm.
Great. So how about we talk about testing, right? So you've got a patient I got hormone issues, I need some help. And obviously you're going to do a good, thorough evaluation workup. But what's a good, thorough evaluation when it comes to hormone? There's different types of testing that can be done. There's blood testing, there's saliva testing, there's urine testing. They must all have their purpose. And we've had people on talk about each one of those things, right? And we've had people say that all those are benefits. So can you talk about, if we're talking about hormones, which testing method, why, or all of them?
Yep. No, I love talking about this because I do think that there is different testing for different people. Now, if somebody comes in and let's say they're a 46-year-old woman and they're coming in and there's menopausal problems and concerns, I'll sit down and obviously get a really good history, look at their timeline, and look at their hormones throughout life. One of the things that I think is really important, and I really go towards urine testing when there's been hormonal problems throughout their whole life, because I want to look at the pathways. And urine testing's major benefit is you get to see the pathways. You get to see where you're starting with the progesterone and the pregnenolone. You get to see cortisol levels. You get to see how that's metabolized. You get to see the estrogen and the estrogen breakdowns into 16-hydroxy, 4-hydroxy, 2-hydroxy. You get to see the testosterone and those byproducts. And so you get an insight too into different pathways like methylation and the 5-alpha reductase and different pathways. So if there's somebody who struggled with fertility, never really had normal periods, had painful periods, painful cramping, things like that, and now are going into menopause with all these symptoms, I will definitely lean towards Dutch testing, which is a spot urine testing that's very popular. And it's changed urine testing. You know, before Dutch really came out, we had to have then people collect their urine for 24 hours, which nobody liked to do and carry around their urine all day. And we also then didn't get a great breakdown of the adrenals and the cortisol because we just had that one big bucket of urine to check. Now with the spot testing, we can see how your adrenals are working and your stress response is working and get all that good information about the pathways. So if somebody's had a lot of hormonal problems, or if they're a younger woman and their hormones are all across the board, that's definitely my first go-to is the Dutch testing. If they're coming in and they're menopausal and they'll say, you know, this really hit me maybe at 42. And since then, you know, I just feel like I can't sleep well, that I'm irritable, and it just seems to be getting worse and worse. I do lean towards salivary and saliva because you do get a better marker of what's getting to the cell. A lot of times too, you just get a better indicator of that estrogen progesterone ratio, which is so important because sometimes it's that woman just needs some progesterone. Sometimes it's that woman needs a little bit more of estrogen and progesterone. Sometimes it's none of the above, and it's just we have to get their adrenals under control. And we get a really, really good marker, I think, with the 4-point salivary that goes along with salivary markers. And so we can look at testosterone and estrogen and progesterone. They then give us that ratio because a lot of times it's not that one or both of them are off, it's that the ratio of estrogen to progesterone is off. So that's where we really have to then focus on that. Plus we get a great idea of where their cortisol levels are when it comes to that curve of the cortisol throughout the day. I do also test blood at times. Now, there's different markers that I really do like in blood. And I like that if someone comes in and I'm also thinking thyroid, maybe I'm thinking too that they have a bad diet and their fish oils or their good oils or omega-3s are off because the precursor to all hormones is cholesterol. So it's really, really important then fish oils and good fats and things like that. So in situations like that, when I think I want a bigger picture, then I'll also mix in blood work. Vitamin D, I like the DHEA sulfate and testosterone in blood. That also can give us some insight into insulin resistance if those are elevated, or to check an insulin, hemoglobin A1C. And then sometimes I will also check like estrogens or estradiol and things like that, just to see where they are, if I'm going to put them in bioidentical, just to make sure where they are to begin with, and that, you know, getting a little bit of a marker of how they're responding if they're getting those levels up. But you definitely get a much better picture of what's going on cellularly with either saliva or urine.
I think that's good to understand that there's different testing for different people instead of just throwing everybody into the same bucket. Customizing it is really important. You also brought up cholesterol. That is very, very important, obviously, for hormone function. I haven't seen more in the last 6 months where people coming in who we suspect have hormone issues, their cholesterol is super, super low, and they're actually on cholesterol meds. Is this something that you see frequently with your patients that have hormone issues?
So it's interesting because I have such an awesome group of patients and such a healthy group of patients that I don't have very many patients on cholesterol lowering meds, which does make me happy because there's a reason sometimes you need to be on those meds, but it's very few people that actually do need to be on those meds. And we, this goes back to our beginning conversation. We, for some reason in our society, have decided that cholesterol should be a one size fits all, which is doing a huge disservice because nobody's cholesterol. I mean, there's so many things that go into cholesterol levels, including like ethnicity, and just different ethnicities are going to have different cholesterol and cholesterol ratios. So this whole idea that anybody who has a cholesterol above 200 should go on a cholesterol lowering medication is doing a huge disservice. And what we do see is that where that really can affect a person is in the hormone world, because they're not getting enough precursors. And again, if you only have so much cholesterol and then you're decreasing what your body naturally wants with cholesterol, the one place where it's really going to sort of take it away is hormones. Because again, your body knows that hormone and hormone balance is a privilege. It's not a necessity. And I know people would disagree with me who are out of hormone imbalance, but the way that your body perceives it is that it's not its first priority.
Yeah. I mean, it goes back to our fight or flight or rest, sex, and digest idea, right? So cells aren't going to be in growth and kill mode efficiently at the same time. It's kind of a trade-off perspective. So you got to, if you're high stress, chronic cell stress, the body's looking at your hormone production saying, listen, I got inflammatory chemicals to make, I got steroids to make, I got cell membranes being damaged. These things take priority over just making some estrogen so you can go have sex or feel nice, warm, and fuzzy. It's
Right.
just the way the cell works. There's a limited amount of energy. But I think
when Tarzan and Jane are running away from, like, you know, the wild animals, they're not going to stop and procreate. And a lot of us are running away from stresses in our lives and then wonder why we don't want to stop and procreate. And, you know, that's again, a totally normal response to not want to procreate during a time of stress. But what are we doing a huge disservice is we're not looking to see what the stressors are for somebody.
Absolutely. And I think that, again, it goes down to looking at those foundational things. It's not sexy. It's not necessarily what people want. Really, sometimes people we've kind of trained them in conventional medicine to say, if you got a problem, we'll give you a pill. In this functional medicine model, we're saying, hey, look, the pill's disease management. If you really want to get healthy, we got to look at the foundational things. They're not sexy. They're just things that you just have to do if you want long-term health. Now, I want to go back to the testing thing. One of those things I want to get back to the urine and why I think it's important. I want to get your take on it. A lot of times what we see is people get put on hormone therapy based on just blood value levels, right? And then I see them and they're struggling. They're like, yeah, some of my symptoms are better, but I'm gaining weight, my skin's breaking out, I've got all these problems. And when I discuss testing with them, I talk to them about the hormone, looking at more like a Dutch test, a urine test, because we see the metabolites and what's happening. Can you explain to the listeners why, from a metabolite standpoint, why if their blood hormones are low and their doctor's saying, hey, you need to be on this, why they may feel worse, and why something like the Dutch test, the urine test, could be so helpful in understanding why they'd have a negative impact from hormones when their blood values are actually abnormal.
Mm-hmm. Yeah, no, that's a really, really good question. I think really important to understand is one of the things that I always say is, you know, if we even just look at estradiol is not a great marker in the blood by any means. What we're getting in the blood is not what we're getting to the cell or what's happening on a cellular level. And we're going to see that picture a lot more if we check saliva, which is filtered blood, or whether we check the Dutch urine test or another urine test. If a woman comes in with estrogen-dominant breast cancer, her estradiol in her blood level isn't going to change at all. We're not going to see anything abnormal in her blood level of estradiol. So that shows you how it's not a great marker on what is happening on a cellular level, because clearly that person is having cellular changes and catastrophic cellular changes that have a connection to estrogen and estradiol levels and how your body's responding to them. And we're not going to see that in the blood. I mean, you can ask any oncologist, they're not going to check an estradiol level for an estrogen-dominant cancer. So that just goes to show you that that's not a great marker for what's happening on the cellular level. And like I said, that's why, you know, sometimes I'll take a look at those just as sort of a way to monitor or watch or just make sure that there's some changes, but that I'm never going to use that as the end all be all. It can be a part of the picture, but it should not at all in any way, shape, or form. And the reason why a lot of people will go to that is because it's easy medicine. I mean, it's easier to get those levels and it's easier to understand. Now, when we look at Dutch and urine testing, we get a beautiful, beautiful picture when we do that of how everything is breaking down. And I would even say anyone listening, a good idea would be, you know, Dutch is just all capital letters. It's DUTCH, to Google it and go to the website and you can see a readout. And you can see how you can then correlate it specifically to someone's pathways. And just like you were talking about, you know, the pathways and that there's, you know, all these different byproducts. What happens in a lot of men and women with hormone imbalance is that there is a component of that is off. And there's a process that's off. And so if we can go and really zone in on that, then the body will balance out, especially in younger individuals where they're making more hormones. So they're making more estrogen and progesterone and testosterone every day, is that we don't have to go and flood their system with hormones. That's actually a terrible idea for a lot of people. We need to just support where there's a weak link or a pathway that needs that support. And we can see that on the urine test really well. And so especially, like I said, if somebody has been having hormone problems throughout their life, that's my first go-to is like, okay, let's check your methylation. Let's check your breakdown of 16-hydroxy, which we tend to think is like a more toxic estrogen, to 4-hydroxy to 2-hydroxy. Let's look at those components. Let's see where your testosterone is compared to your estradiol, estriol, and estrone, your different estrogens, versus just trying to put it all into this simplified version, because hormones are not simple. They are a very complex dance. And, you know, sometimes it's just that somebody's testosterone in a woman is doing the hip hop while the progesterone's trying to do the waltz. So what we just have to do is get them all on the same page. And the urine testing, especially through Dutch, allows us to find where things are off tune. So
let me kind of organize that thought, because there's a lot of important stuff there. But I think one of the things that's important for the listener to understand is you could have low blood levels. And blood, as Dr. Meaghan was saying, what's in the blood is not necessarily what's happening in the cell. And we talk about this. There's a huge correlation between when we look at thyroid hormones in the blood and what's going on in the cell. TSH does not represent what's happening with T3 at the receptors of the cell. It just isn't. And so doctors do run a lot of tests that don't really reflect what's happening at the cellular level. And that's part one. Part two is that when Dr. Meaghan's talking about doing the Dutch test, one of the things that's really important is your blood values could be low. You could look like you're deficient. But when we're looking at Dutch, we're looking at the metabolization pathways. And so you have to go through a couple phases where those primary hormones, estrogen, testosterone, DHEA, they have to break down. And what happens many times is the primary hormone gets broken down into its first metabolite or its second metabolite, but then it can't get out of the system. And so if the metabolites are backed up, the primary hormone could look low. And so you might have symptomatology. Your doctor can look at your lab values on blood work and say, oh, you're low. These are all just menopausal symptoms. We're going to give you more hormone. And you could feel worse because you're dumping hormone into the system that can't clear it. It would be like adding more water to a clogged drain. Mm-hmm. Eventually, the sink is going to overflow. And if you don't clear the drain first, then you're going to have problems. And I think correct me if I'm wrong, Meaghan, that's kind of where you were going with that discussion is, hey, I want to look at it. You want to look at it if they've had a long-term health issue, it may be that their symptoms and the problems they're having, even in other issues like thyroid physiology, hey, I can't make thyroid hormone. Well, it may be because you have all this estrogen that's built up over time that can't get out of the system. And your primary blood values may look okay, or they may actually look low, but it's backed up downstream. Would you agree with that?
Yeah, and I think that's really important too, to piggyback off that a little bit. One of the things that I do is when I do use bioidentical, I put everybody on an estrogen cleanse with it and use things like DIM and calcium D-glucarate and liver support, because a lot of women that are having a lot of concerns and problems, they're having them because, exactly like you said, throughout that lifetime and throughout what has happened, they've caused that drain to be clogged. And so we can use bioidentical to get those receptors working again correctly, but it doesn't serve my patients, I think, to do that without also cleaning out those pathways and getting it then so that we're not looking to put you on bioidentical for the rest of your life, but as these receptors are changing because of the time of life you're in, let's clean these pathways up and we get a good idea of what those pathways are doing with the Dutch test and other testing. Let's clean up those pathways, and then we can get those receptors to be retrained and to be trained correctly, and to even wash out some of those large foreign estrogens by giving a little bit of bioidentical. So the key isn't then to flood the body with bioidentical, it's to use the bioidentical to really get the body retrained and to get those cell receptors then to be able to go into retirement without all of these symptoms, because they don't even know what's going on because those drains have been clogged throughout exposure through your lifetime.
Yeah. I think that over time, I think women's health and the hormones has kind of taken a huge shift in, looking at your hormones and becoming more aware, I think is becoming more mainstream, and people are wanting to look at these things. And I think that ties very much into the Women's Health Initiative. Could you explain a little bit about what that is and how that's kind of changing things over time?
Well, I think it's interesting to see this shift because, the Women's Health Initiative it got published around 2002. And what it was is, in the 1990s and early 2000s, we had this thought process that, I'm going to summarize it in my own words, but that, women, we really are like the only mammal that goes through menopause, human women, where we just have a complete downshift of hormones and still get to live. Like we're still alive, but we're just alive without as many hormones. And so their thought process was, okay, there's so many benefits to hormones, especially estrogen. I always tell people estrogen is the hormone of being a woman, and is I am woman, hear me roar. So it's protective cardiovascularly, it's protective with the bones, protective too, and just like how you feel and energy and things like that. So their thought process was, okay, if we could give everybody estrogen during these years, then aren't we going to see all these benefits? Aren't we going to decrease their chances of stroke, see bone improvements, not have this decrease that we see with women when they go through menopause? And we did a one size fits all for the study. We had it was a great study by nature, large population. We thought we were taking out a lot of variables, but what we did is we really did a one size fits all through a large age range too. Not all the women were just in a small age range. It wasn't like we just chose, 48 to 49-year-olds. And we didn't take into consideration some things like, did they have a uterus? Did the uterus come out? Did they have hormone problems throughout their life? Like, why did they lose their uterus? Because usually, women don't lose their uterus unless there's hormonal problems. So, and then what we did was we gave them large hormones. We gave them progestin and fake progesterone, and we gave them estrogen that came from a horse, and, Premarin was the big one. And these are larger molecules. So these hormones have characteristics similar to our hormones, but they're very, very different, and they're much larger molecules. And then what they did is they stopped the study early because they were seeing all these side effects. And so they said it wasn't safe to continue on, which of course, then any woman on hormone replacement therapy got really nervous and said, okay, you need to stop these immediately. And I still, to this day, so almost 20 years later, I have women that come in that are 75 or 80 that were put on hormone replacement in the 90s and have hot flashes and can't sleep and are stuck in these hormone patterns, and no doctor will touch them because they're afraid of giving them cancer, afraid of, decreasing their quality of life or killing them from hormones. And it's interesting because if you do look at the research about the Women's Health Initiative, there has been follow-up where we realized, okay, what we really learned if we looked at this is that hormones cannot be a one-size-fits-all. We can't just give the same hormones to every woman without looking at their specific pathways and individualization and not expect some kind of side effects. Not every woman needs hormones. And we also have learned that there is a difference between the hormones we're choosing. And that if hormones are a good option for you, and again, hormones are not a great option for everyone, but if they are a good option, that we're finding the right hormones in the right dosage and giving the smallest possible to be able to help balance out the body without trying to drive certain pathways with large amounts of hormones and foreign hormones.
Yeah, so I think that what we're learning is it's really got to be individualized medicine for everybody, right? And I don't think that changes whether you have high cholesterol, whether you have thyroid issues, whether you get diagnosed with IBS. All of these things are the outcomes of chronic dysfunction and chronic cellular stress. So definitely, I think it's a shame that some of the things that we actually did to women as we did over time and years. I think it's crazy that we would think that maybe a 65-year-old female has the same hormonal needs as a 21-year-old female. I think it's crazy that we think that if we just organize a person's bleeding cycle that we've fixed their physiology, right? I think that some of these things that we've done are just nuts. And when when women are struggling with issues, the idea that they're hysterical and that we just need to pat them on the back and give them antidepressants is crazy. And, I think that's where the word hysterectomy actually came from, is you've got these women who have hormone imbalances, and somebody decided, well, we'll just take out their uterus and ovaries and then they won't behave this way because it's some kind of problem. I think that's where the origin of the word hysterectomy came from. I think so.
Yeah.
But,
the hysterical part of it. Yeah.
So I hate to end, but I know we're getting close to our hour. We could spend another hour or two. I got about 10 more questions that I'd like to ask, but we'll have to do that another time. So to wrap this up for the listeners, what are kind of the 3 main points that you would want the listeners to understand, remembering that most of our patients are people that are struggling with some type of chronic thyroid issue, and if they do have a chronic thyroid issue, there's no way that they don't have a hormone imbalance or a GI imbalance. All those things tie together. So what would be like the 3 big points that you would want somebody to walk away from this podcast having?
So I think the number one is to go off of that is nothing happens in a vacuum in our body. Obviously we've gone towards medicine that looks at specialization and says, okay, if you have hormone problems, go to OBGYN or an endocrinologist. If you have thyroid problems, go to an endocrinologist. If you have, headaches, go to a neurologist. But the truth of the matter is nothing in our body happens as a vacuum by itself. It's not like one day your hormones wake up and decide to say, hey, I'm bored, I'm just going to cause havoc, or I'm in birth control deficiency, so I just need you to get on birth control. There's something else going on. And I think that's a paradigm shift. And I think that a patient has to make that shift, because so many, and this, breaks my heart, but I see it so often, is I can't tell you how many patients come into my office and I see 2 things all the time. Patients are either like, I'll get through my story really quickly. Like, there's just a couple things I need you to know. No, take your time telling me your story, because it all matters. Don't try to get through your story as much as possible, because we're going to miss things. I care that you don't go to the bathroom more than once a week. Don't think because we're looking at your hormones that doesn't matter. And I hear that so many times, even really during every day, probably, patients just come in and say, I'll make this super quick. And it's like, no, I don't want you to make it quick. I want the full story. So to really get into a shift in your brain too, that nothing happens by itself. Nothing is in isolation in our body. When we look at this, it's all connected and everything matters. Even, if you were breastfed, matters. How were your hormones? How old were you when you got your first period? I don't care if you're 55. I still want to know that answer. So really doing yourself a huge service, because the second part is I do think we all need to be our own health advocates. I think we need to build a health team and find people in our team that are going to help us get those answers, because we're all a little bit biased. I would never have found the answers that I was looking for by myself. Because I was biased, and I had gotten to a bias point where I was just like, okay, I'm overreacting. I'm healthy enough to be a Division I swimmer. Just settle down, Meaghan, and get on with your life. And, we need to be our own advocates, but we need to build a team of people that are going to help us be able to find answers and to get the solutions to what we know is not right. And then the third is, I just don't think ever underestimate the importance of lifestyle changes. Dietary changes with hormones. I mean, I have women that come in with hormone problems sometimes when they're pregnant, so we can't do anything, or breastfeeding, but we can put them on a low inflammatory diet, like a Whole30 diet, and see huge changes. And so, good sleep hygiene, good stress management, lifestyle choices, nutrition. Don't underestimate the importance of those, because I would think that after a couple decades of, helping people, that I would have thought at this point, with all the schooling that I did and all the studying that I've done and all of those things, that I'd be sitting here and just talking about the latest and greatest with medication or supplements or things like that. But it's so crazy to me that really the thing that matters is our emotional states and our sleeping patterns and the way we eat, and how we can't really get changes without that foundation of what's important. And so everyone can start somewhere, because we can all start by changes that we can make that are going to help all these pathways, and they're going to help, our immune system, our hormone system, our nervous system, our gut, everything, because we can get ourselves out of some of these cell danger responses.
Awesome.
That's awesome. So yeah, I think you said some really, really important things there. Definitely the importance of lifestyle issues, all those things need to be taken a look at. I think to add to that, if you have I think you need to understand that specialty is, when people go into become a specialist in something, that's awesome. We've learned a lot from people who are just delve into one thing and become real specialized, but we've got to be careful too, because as you've said multiple times, everything ties together. So you can be specialized to one aspect, but you have to really understand how everything is interconnected, especially when it comes to hormones, but everything is interconnected. And definitely, I think for our patients and our listeners, they have to understand that, you know, nothing is happening really by an accident, right? Everything's happening for a reason. So before you take something, before you try and suppress something, before you just say, oh, I got my hormones are wrong, I'm just going to load up on more stuff, we have to start to ask the question, why is this happening? Is it abnormal? Is it appropriate? Is it normal and inappropriate? We have to ask those questions. We have to do a better job of interpreting what the body's trying to tell us versus just trying to flood the system with more stuff. Because I know we've grown up watching TV, and every commercial on TV is about, hey, if you have this, just take this. If you have that, just take that. Please understand, for the listeners, when you go to see somebody who's more involved in functional medicine or integrative medicine, when we're doing, many times what we're trying to do for you may not necessarily be what you want. You just want the quick, let me give you my story quick, you give me a quick thing back. That's allopathic medicine, acute care model. When you're coming to a functional or integrative practitioner like Dr. Erica, Dr. Meaghan, myself, we want to help you with a Band-Aid approach, but we know the long game is all about helping you understand what your labs mean, what the tests mean, what your symptoms mean, what your story is telling us, what your timeline is telling us. Because if we can look at those things and do a better job of interpretation, it's less about the supplement, it's less about the medication, and more about fixing the physiology. And diet, lifestyle, and sleep and stress are what create the problem. And so many times the simplest way to get you better is to fix those things, not to give you more stuff to flood the system. Okay. So any final thoughts from either one of you guys?
No, I just think, I mean, it's things like this that I think help people, is that so many times I think we're not talking enough about hormones and thyroid. And, you know, some people will think that this is too geeky, but it really isn't once you start talking about it. It all makes sense, and our bodies all make sense. So I just think conversations like this are so helpful, and for people to realize that there is reasons and that they need to really keep diving in and finding those reasons, and then solutions will come.
Yeah.
Awesome.
And I think that the reason we do this podcast is to educate people, to give them the knowledge that they know, to kind of help them along this journey, and that shift that you were talking about, where you've got to realize that it's not just take this pill and it'll fix your hormones, that maybe there's something deeper that we've got to look for. We do this podcast to kind of open people's eyes, whether they want to try to do it on their own, which is great. You can start there. And if you're not getting where you need to be, then that's where you need to go to somebody who can do specialized testing and really help point you in the right direction.
Yeah.
Excellent. So Meaghan, can you tell everybody where they can find you? Talk to them about your podcast. Tell them what the Academy is all about.
Okay. So I have a podcast. It's called Beyond the Basics Health Academy, or btbha.com. And so you can go to Beyond the Basics Health Academy or btbha.com and find it there. I also have a clinic in the Twin Cities area in Minneapolis. It's called One Agora. Agora means community. So we're trying to build a community here in Minneapolis. But oneagorahealth.com. And that has a link to the podcast, and pretty much everything that I've done is somewhere on that page too. So if you're looking for more information, you can go to One Agora Health, or you can go and find us on Facebook, One Agora Health, or on Instagram. We do a lot of Instagram things too. So One Agora Health is the place to look if you're looking for more information or education from me.
Awesome. So we're going to wrap it up. We're at our time frame. We thank you so much for coming on the podcast and sharing your knowledge with us. We'll definitely get you back on, because I got a whole list of questions I didn't get to ask. And so we really appreciate it. Have a great day to all our listeners and those who view us on YouTube, Vimeo, or on our websites. If you get a chance, please go to wherever you listen to this podcast and put on a review, check that 5-star button or whatever it is, because that lets us know that we're getting the message out and you're appreciating what we're doing. So thank you, everybody. Dr. Meaghan, thanks. And Dr. Erica, I will talk to you again.
Yeah, thank you. Thanks for coming on.
Thank you.